All right, I think we can go ahead and get started. We have a good group here. Welcome everyone to today's webinar on academic and public health partnerships. Just want to take care of a few housekeeping things before we get started. We are recording today, so we will be sharing the recording through NASTAD and RAISE's websites, as well as with those who registered via email. Please use the chat box or the Q&A function to ask any questions at any time. We will have some brief presentations from our panelists, after which we will get into our discussion and questions. So today's webinar is a part of a partnership between the Research Alliance and Implementation Science to End HIV, or RAISE Hub, and NASTAD. This is an NIH-funded initiative that aims to support and provide technical assistance to ending the HIV epidemic, or EHE phase 1 jurisdictions. You can learn more about our work at NASTAD as far as our role as the national TA provider for EHE through our website, and more about RAISE's work with EHE jurisdictions on their website, and we'll be putting those links in the chat. And we also encourage you to reach out if you have questions or would like to meet with the team to talk about how implementation science can benefit your EHE work. And we will put in the chat a form that you can fill out to request a meeting with the team for that. So getting right into it, we have presenters today from health departments and from academic institutions. So our panelists today are Kathleen Brady, who is the Director and Medical Director for the Division of HIV Health at the Philadelphia Department of Public Health. We also have Kendra L. Johnson, who's the Director of the STD HIV Office at the Mississippi State Department of Health. We have Aadia Rana, who's a Professor of Medicine at the Hersink School of Medicine at the University of Alabama. She is also an Associate Scientist at the University of Alabama Center for AIDS Research. And we also have Matt Golden, who's the Director of Public Health Seattle-King County's HIV, STD, and Hepatitis Control Program. He's also the Professor of Medicine for Allergy and Infectious Diseases at the University of Washington. So we will start with our presentations. So please feel free to use the chat and Q&A, as I said earlier, to post your questions as you think of them. And once we've gone through all of the presentations, we will have plenty of time for discussion and Q&A. So over to you, Kathleen. Kathleen, you're on mute.
All right, thank you. All right, so I'm from, as Cooper said, Kathleen Brady from the Philadelphia Department of Public Health. I'm Director and Medical Director, and I'm joined today by my academic partner, Robert Gross from the Penn Center for AIDS Research. All right, so let me give you a little bit of an overview, starting with the Penn Center for AIDS Research. As I said, Dr. Gross is with me today. He is the co-director of the Penn CFAR, which the Penn CFAR is one of 19 NIH-funded CFARs. And includes HIV and AIDS investigators at the University of Pennsylvania, Children's Hospital of Philadelphia, as well as the Wistar Institute. And there's been a long history of ad hoc collaboration between Penn investigators and the Philadelphia Department of Public Health, but the folks at the Penn CFAR recognized there was an opportunity as well as a responsibility to commit the research capacity of Penn CFAR investigators to support the local agenda and establish a formal relationship to advance this objective. And the priority is really to advance local ending the HIV epidemic goals. So in 2018, I became a part of the administrative core as a core investigator to help integrate and align CFAR research and PDPH implementation priorities. And so the Penn CFAR functions as the academic research partner for the PDPH Division of HIV Health. implementation programs. And so this relationship between the CFAR and the health department has been transformative for the CFAR, aligning it as the academic research partner, enabling PDPH data to be used by CFAR investigators, and has been critical to the success of the CFAR cycle in advancing implementation science research. So a key function of the CFAR is to galvanize foundational research that will inform regional implementation. And so this is done partly through Core B, which is the developmental core of the Penn CFAR, pilot grant RFAs, outreach in response to EHE supplemental opportunities, and several special initiatives. So in 2020, the health department, including myself, identified 17 specific questions as critical knowledge gaps for advancing HIV implementation programs regionally. And so the CFAR partnered with the Leonard Davis Institute and issued a call for projects to address some of those specific gaps. And each of the projects is really providing valuable information to the health department, or will be used to modify or develop new HIV implementation initiatives. And there were 4 projects that were funded, and the topics here are including feasibility and acceptability of harm reduction vending machines in Philadelphia, implementing routine opt-out HIV screening in emergency departments in West Philadelphia, evaluating implementation of low-threshold PrEP services in sexual wellness clinics funded by the health department, enhancing HIV testing and PrEP delivery and substance use disorder treatment programs in Philadelphia. So the CFAR also does outreach to support PDPH EHE priorities. And so they identify and engage experts both within and outside the current HIV research community to work collaboratively with the health department. And so I have 2 examples listed here. In 2020, we at the health department identified a key question of whether a change in our $10 million a year medical case management system funded through Ryan White whether a change in that system was implemented as intended and meeting the desired outcomes of improved retention in care and viral suppression. And through CFAR outreach, they had identified Dr. Sarah Bachman, so hard to say that, she goes by Sally, who's the Dean of the Penn School of Social Policy and Practice and an international expert in MCM programs and has worked with HIV in the past. She applied for an EHE supplement, received it, and has been working with not only the health department, but Lincoln University, which is a historically Black college and university on this project. And so more recent one is that there was a recent call for EHE projects this year to enhance engagement and care for people living with HIV leaving correctional facilities. CFAR did outreach and identified Dr. Melita Engstrom, also from SP2, and that resulted in awarding of an EHE supplement from NIH to study an innovative implementation approach for people with HIV leaving prison, or actually in this case, it's jail. So we also have biostatistical support at the health department funded through the Penn CFAR. We have a master's level biostatistician who's part-time that works on site. She's under joint supervision by the health department and the biostats core leadership. And the goal is to augment PDPH epidemiology capacity, enable us data use, actually health department data use for research by CFAR investigators. And so we have a number of different lessons learned here, and that I think we can talk about a little bit more during maybe the Q&A period, but just to highlight a few, we really needed to emphasize having shared goals at the outset and identify the strengths, weaknesses, and opportunities for collaboration, and acknowledge different pressures and potentially slightly different metrics of success, although most are aligned, helping people, advancing science, papers, grants, and career advancement. I think I go to the last one, is that you can expect friction and don't shy away from it when it occurs. And so with that, I'm gonna stop sharing. Oh, actually, I'm sorry, one more slide. I have my contact information here as well as Dr. Gross's contact information. So I'm going to stop sharing. We can go on to the next speaker.
Awesome. Well, I guess I'll go ahead and jump in. Let me start by sharing my slides. Can everyone see my slides?
No, we can't. Oh, now we can.
Okay, let me make it bigger. Okay. Good afternoon, everyone. My name is Kendra Johnson. I am the director of the STD HIV office at the Mississippi State Department of Health, and I will briefly give an overview of our collaboration with the University of Washington. So first, I'll begin by just talking about why there's a need to collaborate. Within health departments, as most of you all are aware, there's a lot of work to do and oftentimes very little staff to do that work. Also, sometimes there are different expertise or capacities that are needed within the health department to meet some of our goals and objectives of federal grants. There oftentimes are issues related to obtaining appropriate software to achieve some of the things that we want to do within our projects. And then, in the middle of all of this, there's time priorities or competing priorities across multiple grants. So we approached it as a way of how can we collaborate to make the work within the health department achievable, and being able to meet priorities and deadlines that were put forth. So many people may wonder, how does Mississippi collaborate with the University of Washington all the way in Seattle? This unlikely partnership began in 2014 when the Mississippi State Department of Health took part of a core group of health departments that worked with UW's Public Health Capacity Building Center. It was a CDC grant that was UW received funding for. And that really just started the collaboration between us and them. In 2015, CDC released a new funding opportunity for health departments to integrate HIV-related activities into STD partner services. The funding went to MSDH, and we contracted with the University of Washington. And this process included having regular conversations to develop protocols for the work. All of the work happened on site in Mississippi, but oftentimes we participated in weekly meetings over Zoom calls, in addition to some in-site or in-person meetings. And the University of Washington worked with us to develop evaluation plans, tools that we could use for data collection, and they led the data analysis for that project. So from that point on, there was a lot of outcomes from that initial interaction. As you can see, even as late as 2022, we still had work and collaborating with the University of Washington. So this slide just shows some of the work that we've done in collaboration between 2018 and 2022. Most recently, the University of Washington assisted us with some of our ending the HIV epidemic work, where they assisted with our epidemiologic profile and some of the materials that were distributed to the community as a result of the EHE project. So why has this partnership worked? For MSDH, we have benefited because the partnership has allowed us to create new data systems that we've been able to share those outcomes to influence the work that we do locally and drive some of our project areas and the work done within those projects. we were able to analyze data that we had access to, but not necessarily the skill sets to do some of that, the advanced analyses. We have been able to provide a lot of data dissemination products. We worked on 3 reports. We've done 2 manuscripts and 6 presentations, which included some of the requirements for our EHE work. And then some of our MSDH staff were provided professional development opportunities and training. Some of our EPI staff were trained in program evaluation. We had some one-on-one SAS and SQL training, and we were able to have 3 conference presentations as a result of this great work. Some of the ways that UW benefited, they were able to write 3 manuscripts based off of our collaboration. They received 4 research grants with MSDH as a partner, and they were able to provide training opportunities for their students, which included 2 conference presentations and 2 manuscripts. So some key takeaways, before any of this work can be done, there has to be trust, and it takes time, but it's definitely fundamental to do all of the work. And then each side has to be able to see some type of benefit. So what's in it for me? For us, we were able to increase our staff capacity and get some of the work done that we necessarily did not have the expertise for. But despite everything, it takes patience. Sometimes the health system or the state health system moves at a slower pace. So patience is definitely required to establish those relationships. But if you have individuals from both sides who have the same goals and want to see benefits on both sides, then patience is key, but it can be done. That concludes my presentation, and I'll be happy to take questions at the end of everyone's presentations. Thank you.
Great. So I think I will go next. Is everybody able to see my screen? Yes. Okay.
Yes.
Yes.
Right, great. So I'll start off. This is a topic I love to chat about, as does everybody, I think, who's on. And I've done several presentations, and it's so great to see one of my public health partners, Kendra, speaking earlier. So I'm Aadia Rana. I'm at the UAB Center for AIDS Research, and I actually direct the Ending HIV in Alabama Scientific Working Group in our CFAR, and the mission of that is to really coalesce the scientific, academic, and public health efforts and initiatives to help end the epidemic in our state. And I think just to sort of echo what Kendra and Kathleen shared earlier, I mean, a lot of these reflections that we're talking about today are part of long-standing established relationships between our academic institutions and our public health partners. So I just want to share, something that predates even me coming to UAB 6.5 years ago, was the Birmingham Unite partnership, which started in 2010. And it was generated based on a need for a health information exchange to improve linkage to care after diagnosis. And so who came to the table included the Jefferson County Health Department. That's where we are here in Birmingham, Alabama, which, of course, as you know, the health department is kind of home base when it comes to new diagnoses and HIV surveillance in our county. The HIV clinics, so which included the UAB Family Clinic, UAB 1917 Clinic, and our county health clinic, St. George's, and community organizations. And so in the interest of trying to have shared data so that people would be more efficiently linked to care and effectively linked to care, we started this program to have enhanced tracking among these agencies in order to really address some of the gaps in our treatment cascade, primarily focused on linkage. And that relationship has only grown as it relates to programs, research, and support of work in this space. So in 2017, building on this work and sort of using the recently released UNAIDS 90-90-90 initiative, the CFAR formed the scientific working group Ending HIV in Alabama. And its purpose is to support the development and implementation of research focused on the goals of the 90-90-90 initiative, led by investigators with expertise in this area, essentially leveraging established services and scientists from behavioral, clinical core to focus on innovative research in the state. And the goal was to answer fundamental questions about HIV care. What aspects of our approach to HIV prevention and care are effective? What populations are not being served sufficiently or at all? How can we comprehensively yet cost effectively improve access to and engagement with HIV care? And how can we improve outreach to increase knowledge of services available? And then I think most importantly, what broad community assets, resources, or programs are necessary to achieve this goal? And I think everybody on the webinar today will agree that a strong partnership and coalition with our public health agencies are absolutely paramount and central to achieve these goals for a number of reasons. One, they are essentially the hub of all data that we need in relation to both prevention and care programs. And only with their partnership are we able to essentially truly assess the impact of all of the interventions that we develop. So I just wanted to share, in addition to that, a couple of the projects that we have ongoing at the UAB CFAR that are partnered directly with health departments. So the first one is a project looking at time to viral suppression across 3 states in Alabama, Mississippi, and Louisiana. So this involved partnering with the 3 health departments and really focusing on a secondary analysis of surveillance data to identify geographic disparities in time to viral suppression. And as part of that work, we were able to, of course, provide technical assistance and biostatistical assistance to the epi and surveillance divisions of the health departments. And this will inform a intervention to targeted areas that have longer times to viral suppression in collaboration with community partners in those relative areas. I think similarly, another way we're working is in a implementation science project. This is with Mobile County Health Department in Southern Alabama, where we are working directly with the health department to help them evaluate the implementation of evidence-based interventions to improve testing linkage and viral suppression in the county and the surrounding rural areas as well. And finally, Drive to Zero, which is part of a limited interaction cohort RFA that's developed by the NIH, particularly trying to understand drivers of non-suppression. So people who are not engaged regularly in care. Who knows who these people are? The health department does. And so working carefully with them to engage and enroll participants in this study. So again, that we can better understand and inform and implement interventions to improve these outcomes. So just wanted to, put a big picture out there of all of the different projects that we at the UAB CFAR are involved in or support that sort of go across the EHE initiative, most of which are involved with both community and public health partnerships. And just to share, you know, all of the challenges that Kathleen and Kendra shared are certainly our experience as well, but also the rewards. So where we make sure that we understand the that, you know, the added value that these partnerships bring, not just to our respective institutions, but to the community that we serve. I think that is item number one when we come to the table, is to make sure that we're serving the community. I think item number two is to understand bandwidth on both sides of the table and make sure that there's clear communication as to what is possible and what's feasible, and if not, how could we support it or make it possible. And then I think three is to make sure that we're treating each other as partners, not just as somebody who's providing data or somebody who's doing an evaluation, but that we are in fact partners. I think things that would help us improve some of the successes that we've already had and hope to continue to grow include, I feel like on the academic side, we often do get instruction to please partner with community agencies, please partner with your public health organizations. And I think that on the other side, given often limited bandwidth of public health agencies from you know, sort of their leadership and from the CDC, if there continues to be ongoing support from their leadership, that they will, you know, that they should partner with, you know, CFARs or other agencies, I think could go a long way. I'll share that, sorry, just to end, the big project, the Getting to Zero, looking at time to viral suppression. I know one of the reasons why some of the states agreed to partner with us is they had actually just come back from a NASTAD meeting where time to viral suppression had been highlighted as a potential priority to evaluate using their surveillance data. So attending that meeting coincided with a conversation that we had set up as we were setting up this grant application. So I think, you know, those sorts of conversations where there is coalescence of these goals can certainly support our academic public health partnership.
So I think I'm the next speaker. My name is Matt Golden. I'm a professor of medicine in the Division of Allergy and Infectious Diseases at the University of Washington and co-director of the Implementation Science Core for our CFAR. I also direct the HIV, STI, Hepatitis C control program for Public Health Seattle and King County. And, you know, I think I didn't make slides. I'm going to speak more somewhat extemporaneously. I would say, you know, our collaboration between the health department and the University of Washington dates at least to 1971, when on Valentine's Day, we opened the sexual health clinic. And when I say we, I obviously was not there because I was a very small child in that time. And I really credit this to Hunter Hansfield, who's actually on this seminar, and King Holmes. And we've been able to sustain and build this collaboration over more than half a century. In our system, the medical director, me, of the program, as well as the deputy medical director, the other physicians involved, we have 4 ID docs, all of the people providing medical care in our sexual health clinic, and several PhD epidemiologists work for the University of Washington, but are active parts of our health department's HIV, STI, hepatitis C control program. This collaboration over these many decades has led to hundreds of grants, hundreds of trainees, thousands of scientific papers, hundreds of thousands of patients receiving medical care, and I think innovations which span a very wide spectrum of our field. There is no way that a health department in a medium-sized city like Seattle could afford all of these people and all of these salaries if they hadn't been paid for through grants and work done through the University of Washington. And there is no way that the university could have done anywhere near what it's done in this area or gotten all those grants without the health department. So I think it really gets to what Kendra is saying, is that everybody is coming out ahead. We are public, University of Washington is a public university. Our health department is obviously a public entity. The taxpayers are paying for all of it. So it really is incumbent on us to collaborate. And as I think about, what has led to this success and some of the pain points, I think 6 things come to mind. So the first is a commitment on leadership in both those organizations to developing and sustaining a long-term relationship. That this is not about a hookup, it's about the long-term relationship. The second thing, and I think others have mentioned this as well, is sort of forbearance. So you don't leave the relationship at the first sign of a disagreement. You stick it out and keep working through it. I think another key thing is institutionalization. So our faculty have clear public health roles. In my case, I'm the director of the program, and we have associated responsibilities. Another key thing is how the money flows. And I think one of the things that's key for us is that public health buys University of Washington services via an ongoing contract, which the university does not charge indirect costs on. And that contract is then modified annually, but we have amendments in the interim. And so this has created a mechanism for the money to move in a way which is advantageous. And there's about $4 million in that contract every year, but it goes up and down depending on what's going on. I think as you think about this, you have to accept some administrative complexity as a price for expanding the health department's capacity. And every few years, somebody in administration says to me, we would never have done it this way if we were starting again. To which I respond, we would definitely have done it exactly this way if we were starting again, because it isn't just about the administration of the program. It's about our multifaceted mission, which includes providing patient care, research, and educating people. And it isn't just about the administration. I'd say one rule I've always tried to observe is that the health department never loses financially. So the health department does not fund the university's activities. And I've always tried to maintain that one. And then the last thing is that sometimes it's good to leave the org chart vague. So if you think about your family, say if you're married, where's the line on the org chart? Who's on top? Right? You don't have an org chart like that. And so maybe in these sorts of collaborations, we leave it a little vague as well. So all these years, I work with a lead admin person. That person is not my boss, and I am not her boss. To be honest, we've never had a problem. It's worked fine. And maybe it's just as well that we don't define things so rigidly. So that's my last comment, and maybe we can take a conversation from there.
Thank you all so much. That was really great. I think you all kind of touched on this a little bit, but just wanted to provide an opportunity for each of you to talk a little bit more about what challenges you've encountered through these relationships. And I also see some questions in the chat, but wanted to give folks some time to think about what they'd like to ask. So I have a couple of questions to start us off with. And maybe we can go in the order of the presentations.
So I'm unmuted. Okay, so one of the things that I would certainly say has been a challenge is certainly bandwidth on the health department side. The Penn CFAR has been very productive in getting, EHE supplements, ongoing funding after the EHE supplements in terms of, R01s and maintain or, having so many projects going on at where we're collaborating it's certainly seems like a lot sometimes, but I think one of the advantages is, and this is what I tell folks, and it sort of might answer the question in the chat to some degree is that, you know, we don't have the bandwidth to do the work ourselves that the Penn CFAR is doing. And what we get, you know, for you know, the effort that we put in is worth so much. It's just been very, very valuable in terms of, you know, changing programs, new programs, you know, really towards ending the HIV epidemic.
Can I add to that, Kathleen?
Sure.
So I think one thing that has to be said is that there is a price that you pay for doing business with the CFAR, which is you start to get spread thin because you have to vet the project. So I think that is one of the tensions that needs to be, and you're not necessarily going to be the person who says it, but I think it's acknowledged from the CFAR side that we are asking a lot because there's, you know, as you're saying, there's limited bandwidth at the department. There are a few people with the skill sets to be able to view the whole playing field and give advice to the investigators that you're partnering with. But a lot of times that falls on you. What it does, so what you're saying is we can help you leverage resources that you wouldn't ordinarily have, but that also means you're doing a lot more projects than you were doing before, and which you are often you're typically a collaborator on the project and often giving feedback and advice to the investigator. So it does create, I think, you know, we have to acknowledge it does create an additional burden for you, even though you're getting to do so much more than you could have. You are doing more than you were personally before the collaboration started, and we appreciate that, and I think you know that, but I think it needs to be mentioned.
Yeah, and you know, honestly, in order to end the HIV epidemic in Philadelphia, we have to leverage all resources, and that includes you know, NIH funding that's going through the CFARs.
You know, I really don't have much to add. Dr. Brady really summarized it well. Our biggest challenge would be the bandwidth within the health department. We have very little staff and everybody's doing more than one thing. However, one thing that we, you know, keep reminding ourselves is, you know, how is it going to benefit our clients and how can we provide the best services? So if that means that creates additional work for us, we're all for it because the outcome will be much greater by collaborating than us trying to do it alone.
You know, Matt was talking about the funding earlier and how many grants have ultimately emerged since 1971's collaboration started, and we've started to see that we're building. Our collaboration is obviously much younger than yours, but I wonder if for Kendra, when grants are written, can the department absorb additional staff members that are seconded to your department from the grants? So they only may be employed for 4 or 5 years, depending on how long the grant is, but can they be seconded to your department so they're working on that project, but they're also offloading some of the other work that others in your department would be doing so that you can use your funding to get the other activities done? Is that a model that can work?
I think so. That's something that we're starting to look at now. It's especially beneficial for us because we receive so many different federal funding streams. So we're looking at creating how can we minimize the workload that we have within the health department? Where are some of our gaps, immediate needs, and we're trying to build on those needs.
I'll add on another challenge we've experienced in addition, of course, to the bandwidth. And I guess this kind of relates to this as well, is sometimes we try to offset some of the bandwidth by saying we'll help analyze the data or we'll work with you on that. Well, then you kind of run into data use issues, and who's allowed to see what. And we have, and we've tried to work on that where, we'll write the code, share the code, run it, and it's behind servers. So we've tried to problem solve, but we've even come up with some challenges as it relates to that. And I think we're working through it, and it's, and the problem happens where like the one person who finally got it on both sides of the aisle and like agreed, they leave, and now somebody else has come and they don't understand it at all and says, stop, you can't do anything right now. So that has happened on a number of occasions to us, where we sort of almost have to start all over again. I don't have a solution, just wanted to share that.
We have a potential solution in the way we've handled it, and Kathleen can comment on it from the public health side, but from the CFAR side, we've hired those folks through our biostat core. So the leadership of the biostat core supervise the person that we've seconded to the health department as the data analyst. So they're already working with the data so that when people leave, go their master's level, and they take this experience and they move on to get a PhD, or they move on to a more lucrative job in private industry, the leadership have the experience to get people up to speed relatively quickly. That's the solution.
Yeah, we've tried that solution because we're county and a state institution. There have been some problems about conflict of interest, that somebody cannot be both an employee of both institutions. And so we've unfortunately, we are still working on that, but that's obviously been something that's been offered and explored a million times over. We're continuing to do that.
So I have a couple things I'm going to say, and Hunter wrote this long comment, but I want him to say what he has to say because he was there when this collaboration started. I would say the biggest challenge is the administrative complexity, and I would say the best solution to that is to get someone really good to do that for you. So that has always been my solution to this. So we have Elizabeth Barish and Karen Hartfield right now, and prior to that, we had Frank Chafee doing this and Barbara Kreckler. And you can't, as sort of more of a physician scientist type, you can't do this and everything else. So you need a partner who's really good at navigating these bureaucracies, who you can rely upon, I would say. In terms of, a few of you wrote in the chat, how do you work with a health department that doesn't have a lot of capacity? And I guess since I don't have exactly that experience, I'm not sure I'm the best person to advise you, but I guess I would offer one observation with this is when people want to do stuff from the university with our health department, I'm looking for a service commitment. So there's a toll when you come to the health department. And, that toll might be seeing patients. That toll might be helping us with our surveillance reports, if you're an epidemiologist. There are different things we need help with. We only have the capacity we have. We don't have huge bucks within the health department. And my observation is a lot of people are willing to pay that toll because a lot of our academic partners, people in our division, they want to make a difference, right? I mean, their life is not just about writing papers, right? We're all kind of on the same team here. So I don't know that this needs to be a huge barrier to success, but I would say that's just the price of admission. Occasionally you have somebody who doesn't want to pay the price of admission. They're not the right collaborator. Hunter, do you want to say something? Because Hunter was there when we opened the clinic. So he has a lot of experience.
Well, thank you, Matt. I didn't intend to say anything live when I signed up, but I'll just say that back in the 1970s, there was a perception that still exists to some extent of an oil-water relationship between universities and public health, with some stereotypical assumptions about what the priorities were and how they couldn't mesh. When I was hired, simultaneously, University of Washington and University of Colorado, Denver Public Health of the two cities with our comment. We're really the first, I think, the first to essentially combine an STI with academic research and related issues with the public health effort. In my case, I was being hired by the public health department. I had to make it, but I was also being recruited to be full-time voting faculty member at UW, just not paid by UW. And so the health department director required my firm commitment that I knew who was paying my salary. I knew what my priorities were. And you can trust me. Well, he took a chance and hired me, and I was paid by public health. Several years later, my salary line, as I was promoted to associate professor instead of assistant in the university system, my salary line in the university system crossed over to be higher than the salary line in public health, and public health graciously agreed to contract that portion of my salary to the university, with the university and I jointly responsible for generating the remainder of my UW pay line from grants, contracts, and that sort of thing, and a typical sort of thing. That's what happened. I went on the UW payroll. My responsibilities didn't change, either in the academic environment or the public health one. And everything, Matt, you said about flexibility and not throwing the baby out with the bathwater when new problems or administrative issues come up is absolutely crucial to it all. It's been a 40-year successful collaboration in Seattle, and I think it can be elsewhere. That's all I'm saying.
Thank you. I want to make sure we get to the questions in the chat. So I think we kind of started talking about this, but someone asked about strategies around developing partnerships with health departments that don't have the bandwidth to support academic collaborations, especially those health departments that might be low morbidity or don't receive the funding that EHE jurisdictions receive.
Yeah, I mean, before there was an EHE initiative, there were, like I said, these ad hoc collaborations between Penn, actually, and not just Penn. We actually, I cheat on Robert all the time with other academic partners, and it really, I think there has to be a mutual benefit. So if somebody, is, their research idea is not going to further public health efforts, then it's not going to be worth it to them. So you have to come to the as an academic partner, you have to go to the table and be willing to hear what they need and want, and really make sure that there is a project that you can work on that will be mutually beneficial. And a lot of ways to do that. Actually, we've done a number of different research collaborations that involved students, whether they were at Masters of Public Health students, PhD, or postdocs, etc. That's often a way to get things started. And health department data certainly can, I think, be used for pilot data for ongoing, research studies.
Yeah.
So
Prior to the EHE initiative, we used to fund things through just CFAR pilots, and even if you don't have a CFAR at your site, you have other pilot mechanisms. So those mechanisms have worked. The issue of indirects was raised earlier, and certainly you have to pay attention to the department is not going to pay indirects, and the university is going to have to eat it, and you just have to you have to sell to the administrators that it's in their interests to make these sacrifices about indirects, and usually reasonable people end up getting along. But now with the new strategy for the CFARs, it was announced last week at the National CFAR meeting. For the directors meeting, there will no longer be EHE supplements directly to the CFARs themselves. So they're going to be just regular federal grants that are focused on EHE. So if you're in a low morbidity non-EHE district, you won't be eligible to apply for those grants. But if the scientific question is important enough, then it'll be other forms of funding. And so using pilot data from your local institutions is usually the best way to go.
Okay. The next question, it's a comment/question. An additional problem for health departments is that community wants data quickly. They also want evaluations quickly, where research obviously takes a lot of time. Even if you're putting together a proposal for a grant, that takes a lot of time to get funded and doesn't line up with real world expectations. Are there low threshold funding that you all have applied for or utilized that have quicker turnarounds?
I can address this in one small way. So I agree that can sometimes be a challenge. I think it gets to the issue, though, of are you using academic partners to expand your analytic capacity to address things that the community wants? It may not really be research exactly, but again, this is part of a partnership, is you're playing ball with everybody. I think another thing we've done is we fortunately have a little bit of money through the state through which we've established an annual, or every other year actually, new collaborations grant, which funds UW faculty and diverse partners to establish new public health collaborations to advance HIV/STI related activities in the state of Washington. One component of this is always one of the two grants has to go outside of King County, which is where Seattle is, because we are not the University of Seattle, we are the University of Washington. So we need to be doing things in a large geographic space that's not just where I live, and with coastal liberals and people like that. So, you know, I don't know how, you know, disseminatable that is, but I think this has worked some in terms of new collaborations with places like Spokane and Pierce County, Tacoma, and hopefully we're going to have another one now with an area called Yakima, which is more of a remote area, which is a very low-income part of the state.
And one thing that I want to add from the health department perspective is sometimes you have unspent federal funds and a need for some specific service. You can always see if there's an opportunity to pay for time or partial effort for an academic person to assist build the capacity within your health department locally as well.
And we started a program actually still using federal funds, but just on NIH funds. So this was a partnership between our CFAR and our clinic, where we created a program for sort of implementation science projects awarded to community-based organizations. And that's using 340B money, essentially. So specifically cannot be research, but of course need methods and evaluation support, which is what our CFAR provided. So these are small one-year pilot funds that community-based organizations, usually in conjunction with our public health partners, apply for. Again, this is local in the state of Alabama. And so that is a little bit quicker in terms of turnaround and also less in, you know, sort of reporting obligation. There is a little bit of that indirect, the max, this is a HRSA max of the 10% indirects that the institutions that apply need to accept. And so, but that for our community-based organizations has not been an issue. And then the CFAR part of it is us supporting their methods and evaluation. So that is, again, similar to what Matt said. I don't know about like reproducible, you know, in that way, but there are kind of opportunities. We didn't know it was an opportunity till we asked, could we use these funds to support these pilots? So,
yeah, we actually do something, well, or we'll be doing something similar. So we get state rebate dollars from Pennsylvania, which is 340B income off the ADAP program at the state. And there's no actual limitation on the amount of admin dollars that can be used by those funds. And so, and they can be used for evaluation. And so we're actually going to be funding through the Penn CFAR a project related to our new program we're funding through state rebate dollars, a transitional housing program for Ryan White. And so, you know, that's a great resource that I think most states would have.
Can I take a stab at answering the question about the community wanting the data quickly, wants an evaluation quickly, and rigorous research takes quite a lot of time? Because I think Kathleen and I, you may not remember this one, but I think we did address this, and it was sort of how do you eat your cake and have it too? So how do you do a quick evaluation, which, you know, when you say quick, usually the back end of quick is quick and dirty. But quick and dirty often means pilot data for the insufficiently answered question for the rigorous scientific question that needs answering. And so we were starting to embark on smoking cessation research in HIV, and now have quite a few grants in smoking cessation and HIV. But before we did, we wanted to understand what was the landscape. And so quickly, Kathleen was able to put together existing data from the city comparing a cohort of people with HIV and a cohort of people without HIV. They weren't drawn from the same population, so we couldn't make causal inference from it. It was limited from an epidemiological perspective, and you would never have hung your hat on it saying that this is the definitive answer. But we got a very quick answer to the fact that people with HIV were smoking at 2 to 3 times the rate of the general population. We were able to publish that because even if it's flawed, 2 to 3 times is not going to go away when you're arguing from an epidemiological perspective that there's something going wrong in people with HIV and smoking. And then subsequently use that as evidence that we could, number one, collaborate, number two, that the problem was there, and then number three, we were able to investigate it. So I think we threaded that needle by using retrospective data that had flaws that really was not going to garner an NIH grant because you'd never be able to definitively answer the question with these data, but we got the information out there that there was something going wrong, and then we got the grants to do the definitive study. So I think that might be the best example I could give you for how do you satisfy the community wanting something fast, which is going to be quick and dirty, and then also have the academic advancement, and then also line people up to get the grants and definitively answer the question.
Yeah, and that analysis was done by the embedded biostats person, and the first author on the paper was an ID fellow at Penn, who's now a faculty member and who I collaborate with regularly.
And has a K award that I'm mentoring.
All right, thank you all so much. We are at time, so I just want to wrap us up. For folks, if we didn't get to your question or you have additional questions, we'll share our contact information. Please do reach out. We will have some new webinars coming up in the new year, so please stay tuned for that. And here's the email address where you can reach us if you have additional questions. And we will also reach out to folks whose questions we didn't get a chance to answer. Thank you to all of our panelists today for your time and for your expertise. We greatly appreciate it. Thank you to all of our participants for joining. And we will be sharing the recording soon, so please look out for that. Thank you and have a great rest of your day, everyone.